Hi, everyone. I'm Dr. Michael Gonzalez. I'm the administrator for the Samaritan Family Health Network and the Samaritan Medical Practice, which is part of the Samaritan Medical Center. Our primary care sites are recognized through the New York State Patient-Centered Medical Home Recognition Program. And today I wanted to walk you through what our PCMH transformation has meant for our practices and our patients. First, I wanted to start off with a little bit of overview of our organization. The Samaritan Family Health Center is a hospital-based multi-specialty network in rural northern New York. We are the largest primary care group in Jefferson County. We have 7 primary care locations spanning about 47 miles. This includes 28 primary care providers, and we saw more than 76,000 patient visits in 2017. We also, as you can see, have a variety of patient payers or payers for our patient population. So first, I want to talk about why we pursued our PCMH transformation and our PCMH recognition. We really wanted to strive to achieve the triple aim by improving patient experience, patient quality, and lowering healthcare costs. To do that, we know we need to put a structure in place that would help us foster a change which would create consistency among our practices and also allow us something to benchmark ourselves against. We recognize that PCMH is a care delivery model that could help us achieve this. PCMH is where our primary care team could partner with our patients, their families, their appropriate caregivers, and is responsible for managing the full spectrum of healthcare needs of the patients and coordinating with their other clinicians and the other healthcare settings that they have. It also emphasizes the care coordination, population health, evidence-based guidelines, and effective use of HIT to meet the patient's needs, and helps our practices put in place structure, systems, and processes to be more effective. This has provided us a perfect way to create consistency throughout our clinics and to give us a benchmark to strive while we look to meet the triple aim. We have been recognized by PCMH since 2014. We first earned our NCQA recognition with the 2011 standards, and we've continued to seek recognition every year. The new standards have come out, up and including the New York State PCMH program. Before I go further, I wanted to just take an opportunity to familiarize everybody with the concepts in case there may be some people listening who have are not familiar with the concepts. There are 6 areas for PCMH with the New York State PCMH. The first one is team-based care, which focuses on practice leadership and care team responsibilities. The second is knowing and managing your patients, which focuses on what information you collect and about your patients and evidence-based clinical decision support. The third is patient-centered access, which makes sure your patients are accessing care and information how and when they need to. The fourth is care management and support, focusing on how you identify patients for care management and whether you use patient-centered care planning. The fifth is care coordination, which focuses on care transitions and management and tracking of labs and imaging results. And then finally, performance measurement and quality improvement, which ensures your practices are implementing ongoing quality improvement initiatives. So now I want to take some time to share what we did in our transformation process. First, and probably one of the biggest and important things that we did was initially develop a core PCMH team. This team was led by a PCMH champion, and the team is where we engaged our physicians and our staff throughout this process. We also set up teams to review our policies and procedures, who compared our policies and procedures against the PCMH standards to help determine where we needed to make adjustments. We also set up a variety of work groups to help support us in the transformation. We made sure that we included in these work groups all levels of staff from physicians to nurses to front office staff, and that group would help us create new workflows and then also support the implementation with the other staff members. By creating these teams and ensuring a variety of staff were involved, it helped us create buy-in, which was necessary for a successful implementation. Throughout our transformation process, we identified areas that needed additional support, like care management and behavioral health, and we did create a few new positions to help support these areas. As you can see, we hired a new care manager, a care coordinator, a LCSW, and then we also utilized a diabetes educator to integrate into our practices. Health information technology was crucial in our success of PCMH. These are investments that I also think everybody needs to make. If your HIT system isn't functioning, then the data isn't structured right, or the information isn't accessible when you need it, and you're not going to be able to identify the areas that you need to change or adjust to be more effective. We made sure to leverage our health IT to kind of support the efforts as we move forward. This included creating new booking templates, creating different visit types so that we could get the data that we needed. We also created evidence-based guideline templates and resources for our physicians. Additionally, we implemented patient engagement campaigns by leveraging our HIT systems, which would include reminders for patients about their upcoming labs, preventative screenings, or any necessary vaccines that they were due. We worked to improve the coordination of our care. We used our EMR to help us track referrals and also track our ED high utilizers. We worked with our staff and our care coordinators to make sure that we were tracking those patients who were going to the ER, ensuring they had follow-up appointments, that they made those appointments, and that we used our care managers, triage nurses to make sure that they had the medications that they needed if anything was changed during that visit. One of the biggest areas that we did see an improvement on was our integration with behavioral health. First, we created multiple behavioral health screening tools into our EMR, the DAST, Audit, PHQ2, PHQ3s, PHQ9s, and we made them more easily accessible for our nurses and our providers. We have a large behavioral health clinic within our system, but we found that many patients may have been reluctant to go to these providers, either due to stigma, distance, or access. Integrating behavioral health into primary care, we reduced the no-show rates of these behavioral health visits. We were able to pull that behavioral health clinician into the primary care visit at the time that the patient was with the physician. Whenever the physician felt that maybe there was a concern that needed their assistance, severe depression, suicidal ideation, or any other possible condition that may have arose. These behavioral health professionals could go into the exam room. They can do an assessment of the patient. They would be able to do any kind of an immediate intervention, and they'd be able to immediately provide a consultative plan for the physician or the provider in ensuring that the patient didn't fall through the cracks. Finally, I think staff education was a huge piece of what we did, and I think it's important to engage staff along the way for true transformation to occur. We made sure that we reinforced all the PCMH concepts at all staff meetings, whether that be a front office meeting or a nurse meeting. We also made sure that we educated and trained our staff. We created a more robust skills fair competency for staff. We introduced cultural competencies, and we always made sure that PCMH orientation was in the forefront for new staff. So, how has this impacted our practice and our patients? I think it's kind of done so in about 6 areas. One is communication, patient engagement, care management, population health, patient access, and behavioral health. Our most significant areas and impact over the years have really been in communication. And that's communication with all areas of our practice, so between the provider and the nurse and the patient in the office. We have been able to meet the patient's needs sooner and more appropriately through this communication, and I think we've really benefited from our care management program as well. They've been able to communicate and spend more time with patients around their more complicated health concerns. A few more specific results that we've seen. We focused on our patients with A1Cs, our diabetic patients with A1Cs greater than 9%. And in 2016, that was about 9.2% of our population. And currently in 2018, that is down to 7.4%. ER visits over the past few years, we've seen go down to well over 11,000 visits, down to where we'll be probably right around 10,000 visits or so by the end of 2018, which is a drop of about 12% of ER visits over the last couple of years. Finally, we talked about our health screenings. 2 years ago, we really were minimal in our PHQ-2s and 9s, somewhere in the hundreds, and our SBIRTs were 0. And today, as you can see, our PHQ-2s are greater than 29,000, our PHQ-9s are greater than 2,000, and our SBIRTs are greater than 19,000. I wanted to kind of take an opportunity to show you or share an example with you of how we feel that this program has worked for a patient specifically, and walk you through kind of a case study. We had a patient, a diabetic patient who was an uncontrolled diabetic with multiple comorbidities and a hemoglobin A1C of 13.6. He was clearly unable to manage his condition well. Over a 2-year period, he had numerous no-shows, lack of follow-through on appointments and treatment plans. He had over 7 hospital admissions and more than 20 emergency room visits. At that time, we were able to introduce our care manager to him. He was one of the first patients that came to mind when we started this program. And that care manager interacted with the patient, built trust through multiple phone calls, long discussions with the patient on a regular basis. Over time, we saw his A1C level drop down to 6.7, and in a 1-year period with the care manager, he had just had 1 ER visit. So I think by implementing our care management program, it shows how we were able to improve our measures, but it also shows how we were impacting his life. This individual had only a trip to the ER, or he had about a trip to the ER every month over a 2-year period. And not only is that costly, but it shows a really poor quality of life for him. So with this patient, we were able to achieve the triple aim of improved quality, reducing costs, and improving the patient experience. But most importantly, I think we really affected the quality of his life. So for many practices going through the PCMH transformation, there are a few areas that we felt helped us achieve the strong results that we've seen. And I wanted to take some time to kind of share some of those lessons as you go through your PCMH transformation journey. First, I think it's having a strong, knowledgeable PCMH lead, somebody who understands the standards, understands the practices, and knows how to work with people at all levels of the organization. This will all help you. This will also help you with the second piece, which is keeping the PCMH transformation in the forefront of competing agendas. We all know that things come up on a day-to-day basis, and there are other new and larger initiatives that come forward for us. DISRIP and ACO were things that kind of were also competing priorities for us, and we had to make sure that we kept PCMH up front in that endeavor. But it doesn't come overnight, and so you have to make sure that it stays in the forefront and always remains a priority. So keeping with that team approach, PCMH is about the team, and to be successful, you need to have that kind of team approach, making sure that everybody has some skin in the game, that everybody has some buy-in, again, from the entire staff, from the physicians down to the frontline staff. And one of the biggest, I think, reasons for our success is involving our physicians, our managers, and our directors heavily, so that way they could also turn around and affect more providers, and they could interact and lead other managers, other leaders, and they could help with the other frontline staff. They all were involved in creation of policies. We developed the workflows with the representation from each clinic in our work group meetings. Again, front office, nurses, care managers, triage nurses, managers, providers. We all ensured that they came together and talked about issues and solved workflow problems, and that we ensured that every agenda that the organization had, through whether it was a front office meeting, a nurse meeting, or a provider meeting, that we always kept PCMH as a topic on it, what was happening, what was new, and getting feedback throughout the process. One of the things that we did or do now is look at access differently. I think our patient access was previously more provider-driven. It was based on when we felt we could offer appointments and when we thought what the patient needed. If we didn't have an appointment for a week, that meant the patient just needed to wait a week. So we kind of switched that mentality and became more patient-focused, focusing on what the patient needed. We held appointments for higher need patient needs, which meant that if a patient called, that we were able to offer them an appointment in a more timely manner. And this helped get patients in the office and avoided urgent care visits and ER visits. As I kind of previously mentioned, the health information technology was a big piece of our success for PCMH. And you also want to make sure that you invest in your EMR and the IT portion of it, because that will definitely help you meet your goal. And finally, just kind of remembering that PCMH is a transformation. It's not just a checklist. It's a way of practicing care that you need to live and breathe every day. It's not simply a checklist, and it's taking the time to help people understand we're not just going and checking off the standards, but we're trying to figure out how to implement those in a way that's going to be beneficial to both the office and the patient. After earning recognition, the journey can't stop. Again, it's an ongoing process. So the PCMH model is a way of practicing care, and it's important to make sure that we keep our PCMH team together. We continue to meet, we continue to communicate throughout all levels of the organization, keeping the PCMH transformation in the forefront of everybody's mind. Our leadership team and our work group meetings continue to occur. They continue to fine-tune the process, and we continue to look at more ways and more processes to make everything more meaningful for our patients. So overall, this has enabled us to kind of continue and improve and provide better patient care. Thank you for your time today. I hope this was helpful, and I wish you the very best on your PCMH transformation journey. Thank you.